were together in Malaysia. That would be a very long time back, almost 20 years now. But life has been, um, in the fast lane always for both of us. And I just wanted to tell you about what we have done in in the past few years. What we have done. So when you said Afghan Neurosurgical Society, I just wanted to tell all my friends there that, the best work in the world, if you want to do, you really don't have to be in a place like in the big cities or the happening countries or anything. You can be anywhere and things will happen because mind is the greatest lab. The lab, any lab that you want, it's your mind. Okay, so you can do anything anywhere. This is the first thing I would want to say. Most of my innovations and my vision was done in Nepal. In Nepal, we didn't have much to go on. I mean, when I started, I remember I just had a semi-working bipolar, a microscope with just one eyepiece working, and that's how we started. So I tell to all my students that if you want to really do something, you can do it, and for all the rest, you can have excuses. So we'll start off now.
Sure. We cannot see your slide actually. It's looking the Zoom.
Can you now see? Can you now see?
No, we cannot see. It's just like the whole screen is sharing. I cannot see in my hand. Rashad, you can see it on your hand?
I can't see anything either. It's just a gray blank screen.
Okay, so I will share again. I will share again. 1 second. Can you see now?
Yes.
Yes.
Coming up, yeah.
Okay, great. You can see now?
Yes, yeah, we can see it.
Okay, great. So this was the first disruption that we did. And oh, what a disruption this was, because it changed the entire trauma scene. But when I started it in 2007, accidentally, of course, in a place where, I had gone for 6 months. I never thought this would become a textbook or it would be a session, one of the sessions in a WFNS meeting. Today, it's been taught in over 80 countries. Now, the Cusco consensus put it as equal to decompressive hemicraniectomy if you have the skill for it. And every day I get at least 4 to 5 messages with videos from young neurosurgeons, how they were able to do it and how the results are different. But it took me so much time. It's almost 20 years, 2 decades since we started it. Probably Javed knows when in 2009 I was presenting it in Malaysia, and there was no acceptance at that time. So remember, every disruption that you do doesn't have to be accepted straight away. It'll take its own sweet time, but then if you are brave enough to carry on, taking all the roasting and taking all the problems that comes with it, you definitely will succeed. So this was how we started cystonostomy. And after we started cystonostomy, next thing, we wanted to figure out how the brain is cooling and cleaning. Now, this was a byproduct of cystonostomy. It was a byproduct of cystonostomy because we figured out that the CSF must be entering the brain through Verschoorhaben spaces. So we asked the question, why does the CSF enter the brain? And we figured that it must be for cooling and cleaning because the universe is extremely intelligent. And if we could tap into, understanding that, there's so many things we understand. So we tapped into that and we figured out. And then at the time when we proposed this was a crazy idea. And, later on, this now, if you search how the brain cools and cleans, this is the first paper. This was a chapter in Springer Neuro. And then we went on to understand skull base. As I went on to understand skull base, I figured that the skull base was primarily built around the structure called carotid. So if I could understand the carotid in the skull base, I could understand the skull base. So here we made a very simple classification saying that all vertical segments of the carotid are odd numbers. So imagine you have C3, that's a paracellular, C5 paraclival, and C7, the parapharyngeal carotid, all of them odd numbers, C3, C5, C7, all of them vertical. And then we reconstructed that's a petrous carotid, C6, C4 is a horizontal, intracavernous, and C2 is intradural carotid. So then we had petrolingual ligament, anterior clinoid process, posterior clinoid process, third, fourth, V1 nerves, third, four, V1, V2, V3. Then you had the Vidian nerve, which then we had the facial nerve, the cochlea there, and the clivus there. And then you had the proximal dural ring, you had the distal dural ring. So, then you had the eustachian tube there, lateral to the carotid. You had the foramen rotundum, the foramen ovale. And you see, before you know, the whole skull base was being reconstructed. So fortunately, this was one of the classification which is now accepted as a trinity. Of the ICA extradural classification. Boutiliers, Labib, and Kassam, and my classifications is accepted as one of the three classifications which are being looked at. And it's a very easy classification. Then we went into I wanted something beyond the microscope. I named it hyperscope, and this was way back in 2011. We went and started writing about the exoscope. I used to call it, as I said, I used to call it the hyperscope. And this was the hyperscope. Basically, I wanted all the things, navigation, electrophysiology, scans, the operative field, everything into one field, and that too registered. So let's say that if a pilot wants to land a plane in dark, he should still have assistance so that he sees the entire runway as it is without even light. So with virtual reality, registered rendering. This was the feature of hyperscope. So I'll show you more things about it when I talk later, but this was my concept. We wrote it in the textbook. We didn't patent it. And then we created the first exoscope. And Axel Pernesky had done an exoscope, but nobody had done a robotic exoscope. So this was our work in Alicante. This was 2 universal robots, robotic arms, and my engineer was Eduardo. I was doing it with Pablo from Alicante University, and this was what happened. And this old 2011, 15 years robot could do mostly what current exoscopes cannot do. It is identifying a small mark in this skull and then bringing it to the center. This is called intuitive vision. And the present exoscope, the Sanma Yoko, can do this, but no other exoscopes in the market is able to do this. You can see the mark and see the mark being brought to the center. This is the exoscope doing it. You can see the code running in the background. And you see this is Eduardo, my engineer, and he could also, we hacked all those things from Medtronic. You must know that when you are in Afghanistan or Nepal, you can afford to do this, not in Europe or United, doing these things. You got all this, and we could even move this scope the way we wanted. And today, with the San Mayoko, I can still do that. We got all this into the San Mayoko exoscope as well. And so this was what we did. And so then when the exoscope came, the Esculap exoscope came, we started looking at minimally invasive approaches. And you can see this is a petroclival cystic solid mass. That's a basilar there. So retrosigmoid, and then pulling this would be terrible. So what we did is we did a very small craniotomy, a tailored Kawase approach, very tailored Kawase approach. It's a 2.5 to 5 centimeter craniotomy. And then cutting the tent. You can see that the tent is cut. I don't pull clips and then I entered the Meckel's cave. And right between the 5th and the 7th nerve, that's a tumor. That's a solid portion of the tumor. I'm still cutting the tent, the last portion of the tent. That's how you enlarge these windows. So you can see I'm over the tumor, and you can see that's a tent, and you will see the 4th nerve now very soon. That's a 4th nerve entering the tent, and that's a brainstem. That's a tumor. So once I cut the tent, I have a huge window between the 7th nerve and the 5th nerve. You can see this petroclival meningioma, I'm just doing it between the 5th and the 7th. This is a petroclival angle, okay? And you can do best, you can do your basilar aneurysms, ICA aneurysms, petroclival tumors. Anything in this window can be done. I mean, people talk about endonasal approaches. We have done some really interesting endonasal approaches, but then I don't think it is required, because for the Kawase, I really don't think endonasal is required. I mean, I see a lot of people going to the Petrus apex with the endonasal. Well, you can do that. We will show you something of that sort as well, but it's not required. So this is just between the 7th and the 5th nerve, and we can take out everything. So you can see the 5th nerve there, retrogazerian 5th nerve. That is the 7th nerve. You're taking out the tumor from between these two. And it's possible because the exoscope can be maneuvered with my feet. With my foot, actually, not my feet, one foot. And you can, you're using something called a total internal decompression. You're not pulling anything till you find the capsule. Then we have made our own robotic endoscopic holder. So you can put in the endoscope and see, look for the basilar. That is that we identified. And that is what you're worried about. You keep on taking out this tissue till you find the capsule. You mobilize the capsule very, very gently till you break the capsule. You see the movement possible with the exoscope, and immediately zoom and focus. And with a half screen, with the endoscope, that's a 10 millimeter 3D endoscope, I can see the basilar, and I can see even the perforator of the basilar. I can see there. Okay, and then I can see what is there to take. So we are taking out all those capsules. You can see the perforator and the basilar now on the exoscope. You can see that it is between the 5th and the 7th now, completely between the 5th and the 7th now. Everything is being taken out. So another cavernous sinus lesion. This lesion, the cavernous carotid, is completely encased. We had a lesion like this yesterday. My team was operating. So this is a meningioma. This is our technique of meningoorbital band opening and going, taking the temporal lobe of the cavernous sinus. We described that many, many years back, published almost 10 years back. So you can see the tumor being taken out. This is the cavernous sinus. These are the nerves. This is the clinoid process. This is the 3rd nerve. I am dissecting the 3rd nerve. That is the roof of the cavernous sinus. And this is the only way I will know where are the nerves. When you deal with the lesion in the cavernous sinus, you have to always go to the clinoid. You have to go to the superior orbital fissure. And this is the way that you will know the line of the nerves. Otherwise, while taking a tumor, you can go right through the nerves without realizing it. See, now I have defined the nerves. Once I define the nerves, so you have the third nerve there, you have the fourth nerve. I'm going between the fourth and the V1. I know where the sixth nerve comes. I'm taking out the entire tumor off. Very clean, very neat. Just because it's cavernous, you can see the entire anatomy so beautifully. And it's completely extradural. Everything is extradural. No opening the dura at all. And this, I wanted to show you the Sylvian dissection, and we call it ultra micro neurosurgery. And this is because zooms of up to 100 is possible. In fact, zooms of up to 150 is possible on the new exoscope. And you can see the operative technique. It's not the tool. You must remember, it is, if you are a fool and if you have the tool, you'll still be a fool with a tool. Okay, so there's no point just having a tool. You must be able to dissect with 3-hand dissection. You should be able to have traction, counter traction, and very good surgical technique to go ahead and dissect this. You can see now how we are going ahead and dissecting each bit. Zooming is also not very fast, very careful, very, very elegant dissection. There's a ruptured aneurysms. You're going all the way. You can go all the way to the other carotid, all the way to the other MCA. If you are slow and patient at very high zoom. The only other person who used to do very high zoom and very clean dissections, of course, other than the Japanese, that's and Tanikawa, I remember, is Yuha, who and both used people want to get the Did I drop out?
I think, yeah,
Hello?
you have dropped out, IP. Yeah.
Shall I share again?
Yes, please.
Yeah. Can you see? Can you see my screen?
Yeah, it's coming up.
All right. So I was just showing everybody as to how we go ahead and do these dissections, primarily the arachnoid dissections. This is an intravenous dissection. It's at very high magnification, much more than what the microscope is capable of. So this way you open up the entire highway. And this way you can mobilize the way you want it. You can even mobilize it from the dural sheath most of the time. You can see the dissection now. You can see the vessel there. And how you dissect all the way across the optic nerve into. So it should be a wet and dry field. In fact, we created something called the Nuka retractor, which has, it's a Nuka company, it's a Santana retractor where we can actually have wet and dry field without irrigation. So the retractor has very small holes which will irrigate, and it has small pores for suction which will suck. So now I'm going past the optic nerve. You can see I'm going past the optic nerve. Now, without even taking, even the smallest vessels are being preserved. Only arachnoid is being cut. These are videos from 3-4 years back. So, as I told you, after cystonostomy, we described the cleaning and cooling. Then we talked about hypervision, which is translated into medaranya. We talked about exoscope. All this work was done in Nepal. And you can see how I open up the arachnoid there and go to the other side of the optic nerve, and you can see the carotid there. And if I keep on further, I can go all the way to that carotid bifurcation. So that's the beauty of this kind of dissection. You can see both the optic nerves, that's the other side carotid. And if I dissect here, I can go to the other carotid bifurcation. These are some interesting endonasal cases. Again, I wanted to tell you what is the importance of, this is a large pituitary tumor, but also here, we must understand when you take the tumor, some people say, oh, I went into the third ventricle, I could see the third ventricular structures. Not right. If you do that, it's not right. So we wrote a paper, and most of these papers are published on Facebook. I didn't want to publish it on some journal so that nobody sees it. So I don't think I am, we were disruptive enough to think that we don't want to be published on some big journal. The big journals are there only because of us. Okay, so Javed knows I was a rebel from day one. So we published most of these in Facebook. You can see that the complete tumor taken, but you can see how we dissected it off the diaphragm. That's a diaphragm. So we kept the diaphragm complete, and you can see another case. Well, this is the post-op of the pituitary. This is another case. You have to take note of myelocytic astrocytoma. And you can see how thin is this brainstem. And you know what is the important thing about this? Is not a chordoma. The chordoma, the basilar would have been here. Basilar would have been, because the chordoma would arise from the clivus, and the basilar would have been pushed back. But here, the basilar is right in front. But fortunately for us, the basilar is on the right side. Okay. So if I mobilize the corridor that will limit me here is the sixth nerve. The sixth nerve, if I'm able to mobilize it away by sphenoidal ligament and the petrosphenoidal ligament and getting into the Gulfar segment of the cavernous, I'll be able to mobilize large flow between this and this. But you must remember the basilar and its perforators. The basilar has perforators going on. You have to be between your resection is going in between these perforators, between the sixth nerve and between the basilar, and you have to take it out. Okay. When we did that, I don't think anybody in the world had done that. But again, this is disruptive innovation. And the belief that you could pull it off. And you can see posterior clinotic sella dura is being exposed. Vinod Felix was been associated with me for over a decade. Each other. So now I'm going to open the dura, and you can see that once he's got me you can see both vertebral is always wet nerve, which the sixth nerve, you can see that it is now mobilized this side. That was a vertebral artery. This is the tumor that is perforators now. And that is one perforator. This is the vertebral artery. The sixth nerve is here. This is how the tumor is taken out. Okay. So once the tumors, this patient came to us on a wheelchair. The last follow-up, she was completely okay. That was 4 years back. This is one of the things that we made. This is a Franca Emica robot, which Vinod is operating with that as an endoscope holder. And this is a pica aneurysm. And according to the principle, cranial nerves should not be, gone through a lot of moil, but this one, we did it through the nose. So that's the endoscope. So that is a vertebral temperature. These are the 12th nerve rootlets, the 11th and 9th, all those rootlets are behind. So we have to go between the 12th rootlets, and you can see that is the annual one side. They set the 12th nerve off. You can't clip it through the 12th nerve because you will have 12th nerve palsy. You're going between. I don't have 3D, so that is a clip now. This is one of our new, for the last 6 years, we're doing it for, this is called the X-Pajaf approach. This is called the X-Pajaf approach. The X-Pajaf approach is something that we use for glomus jugulare tumors. So this is parasigmoid drilling, and I open the sinus, take out the entire tumor, clip the entire sinus off. And instead of having cranial nerve palsies or something, myself and Dr. Sampath Chandra Prasad was we were both reason why we made this approach. And now the ENT surgeons are also starting to adopt this approach. Earlier, they had to translocate the facial nerve for these large, and you can see how vascular this tumor is, because I have already controlled the supply. Ascending pharyngeal artery and other branches of external carotid is already, it is not, we don't have to do an interventional procedure to take off the supply. We can do this during surgery. Okay. And all this tumor we can take out. This is a glomus tumor. Now we are opening the sinus, going inside the sinus, the jugular bulb, going inside the jugular bulb and taking tumor off. This is open sinus. This is the sinus which is open. And, we put some glue. Again, our creation glue is just gel foam, which is crushed and mixed with fibrillar Surgicel, and that is our glue. Better than any other glue. I think Johnson & Johnson and all those guys will be very unhappy with me when I say this, but this glue is better than any other glue. And if we have vascular injury, we use crushed muscle with one layer of Surgicel. That is better than anything else. So these two things are for hemostasis. It's excellent. So now you can see completely removed jugular foramen and small retrosigmoid craniectomy, craniotomy, and then a small extension over the sinus, and then you are able to take out this tumor. Okay. And a lot of people are still not, young neurosurgeons are not able to understand CP angle. The conventional way of CP angle surgery is that you do a total internal decompression and then you take the capsule off the nerves. The problem is what happens is if you do that, you may be able to save the facial nerve most of the time, even up to 4 centimeter tumors. But if you dissect the capsule, you're never going to save the hearing. It's impossible. Okay, cochlear nerve is impossible to save because the capsule and the nerve shares a vascular supply. And so if you pull the capsule anything more than 2 centimeter, if you pull the capsule, you may be saving the cochlear nerve anatomically, but there'll be no hearing. So what we went ahead and did is we did something called the total internal decompression. Okay, total internal decompression. The idea is instead of dissecting between the capsule and the pia arachnoid of the brainstem as well as the nerve, what we did is we went inside the capsule. We went inside the capsule and then we would remove the entire content of the inside the capsule. Okay. The complete, it is not partial. Roy used to do, the CHUV people, they used to do a partial internal decompression and leave the rest of the tumor over the facial nerve. But what we do is with high magnifications and endoscope, we are able to cut a large window into the capsule, stay completely intracapsular. And all my team is now in parallel. They are doing this right now. So we are able to preserve every nerve, 7th, 8th, every single nerve we are able to preserve. How much ever big the tumor is, well, if the tumor is huge and the 8th nerve is irreversibly gone, yes. But if the facial nerve is present, we can preserve the facial nerve like this. This is called total internal decompression. All the youngsters watching this, you must remember, there's a lot of people talking about, very confusing concepts in vestibular schwannoma surgery. Vestibular schwannoma surgery is the easiest surgery. If you first identify the capsule and after that go inside the capsule, take every single bit of the tumor from inside the capsule. And then you can see the 7th nerve. You will need a 7th nerve intra-op neurophysiology monitoring, because you would want to see where the facial nerve is. You would want to see, where the vestibulocochlear nerve is. Okay. But this capsule is actually the perineurium of the vestibular nerve. So you stay within the perineurium of the vestibular nerve, drill the IAM, open the capsule all the way in. Don't try to pull the capsule off the nerve. Just stay inside the capsule and take out every single thing. You asked me about recurrences. In the last 10 years, we hardly had any recurrences. So you don't have to worry and your patients will be safe. Another concept that we developed was a multi-window total internal decompression in craniopharyngiomas. A lot of people talk about craniopharyngioma, capsule delivery and all that. Let me tell you, having done a lot of craniopharyngiomas, if you don't have the common sense to understand that craniopharyngiomas arise from the pituitary stalk, and if you pull something away from the pituitary stalk, and especially when the craniopharyngiomas are big, they are associated also with the hypothalamus and its perforators. If you pull, yes, sometimes you're lucky, and then of course everything comes out without any problem. But do you want to do your surgery based on whether you are lucky or not? No, obviously you don't want to. You want a margin of safety. If somebody if you ask the pilot and then, you tell the pilot, can you land the plane? He says, if I'm lucky, I will land the plane. Of course, you're not going to be in that flight, right? So so what I do is I do multiple windows, multiple windows, and get into the capsule, take everything out of the capsule, all the tumor. Okay. If it is cystic, no problem. But if it is not cystic, I take out everything. People say the capsule grow, that grows, this grows. You can radiate, but you don't want to destroy the patient. So this is the multi-window total internal decompression in craniopharyngeal mass preserving. This is another disruptive approach that we started. And all our instruments, I can show you something. Let me show you a drill. This is a drill. So this is for endoscopic approaches. You see, you don't have to do a transmaxillary transpterygoid because your line of vision, we have the endoscope that can bend, and we have the drill that can bend. Okay. Another thing that I want, especially in the third world countries, is so many strokes. There is this study done in the West, which is a very, very badly done study. And it was comparing STMC to aspirin, and they noticed that aspirin is better than STMC. There are two big flaws of that study. Number one, they were doing ST to M2 or ST to M3, which is not a good idea. You have to do a ST to M4, and what happens is it revascularizes the penumbra. And penumbra is the place where the umbra, after losing the umbra, the plasticity for the umbra comes into the penumbra, not some area which is 5 centimeters away from the umbra. So it improves the plasticity and prevents further strokes. So we started doing this STM4. We are doing it in Parul now. I think Barrow has started. The Chinese have started. Bill Coldwell in Utah has started, but we started it almost 10 years back, STM4 anastomosis for strokes. We were using first highly magnified microscopes for that with on the Pentiro. I put on a 3-step magnification changer, thereby increasing the magnification to 40. But right now we use the exoscope for it. You can see that this is the M4, and that is a 0.6 millimeter vessel. This is a 0.7 millimeter ST, and you can see about 12 to 14 stitches using 11-0 interrupted stitches. And they do a fantastic job. Okay, we've had many patients who's improved so well, and you can see in Moya sometimes you have a 0.6 millimeter vessel, and this is a 0.25 millimeter M4. And of course, there are other things also we can do, but you can see that is the level of bypass you can do. Okay, it is a 0.25 millimeter, 0.7 to 0.25. I mean, I don't think anybody else has ever recorded anything smaller. Even the plastic surgeons, we were asking around, if anybody is recorded smaller, we can go still smaller. There's no problem. So this is what we can do. So this skill of doing it doesn't have to be in the first first world countries. It can be done anywhere, and I'm sure all of you are very skilled and you can do it too. This was when we were in the ACNS. This was our exoscope, the San Mayoko, with Taki, Ashish, and Keiki, all my other friends. So future directions for STMC stroke, I hope it will be taken, like cystinostomy, it will be taken up over all the third world where stroke is a big problem. And this is our instruments that we made. We made this entire set at the price of half the price of a scissor from the West. That is what we did. Okay. And all of them are excellent instruments. Right now, I can proudly say that Professor Luis Borba, the current chair, he uses one of these sets. And this is another approach for the anterolateral corridor. So we combine suprabrow, transorbital transcavernous, and endonasal approach. And, the whole is greater than its parts. The three approaches put together to just a brow incision, which can take anything in anterolateral corridor, anything. Okay, be it trigeminal schwannoma, be it a basilar tip aneurysm, be it a clinoidal meningioma, acom aneurysm, paracellar aneurysm, anything. Okay, proximal MC aneurysms, anything can be done with the suprabrow, transorbital, transcavernous, and an endonasal combination. You don't have to do all things together, but this is the cadaver dissections in our lab. Parul has a beautiful 3D lab, and this is the exoscope. And my colleague is doing this approach. You can see that he's I mean the entire cavernous sinus. So he's doing it through the orbit. So taken the supraorbital flap, and then you can see the third nerve, you can see the carotid, you can see the optic nerve, and between the optic and the carotid will show you the basilar. You can see the A1 there. So this is just through the orbit, and you can see the basilar there. Everything. So it's a transcavernous approach on this side. The cavernous sinus is completely seen. That's the orbital roof. The orbital roof is taken off with a small craniotomy, and combining both together gives you a fantastic corridor. This, we call it the mosaic approach, and I believe this will replace all the Kawase, Dolench, everything, because it's a learning curve is very steep. Once you understand this anatomy, I believe it'll be, and with correct tools, intraoperative imaging, neuronavigation, all that. And my friends in Afghanistan, please don't think that you cannot get all this. It is, if you want it, it'll come. If I can do it in Nepal, you can do it very well in Afghanistan. Okay. And this is one of the anatomy that you will see. So you can see that is the vertebrobasilar junction. That is the third nerve. This is the PCA. This is the SCA. This is the fifth nerve. Fifth nerve is here. Seventh nerve is down there. That's the entire pons. Okay. And this is the anatomy you can see. Carotid, optic, everything you can see with the mosaic. And our gradual progress has been like this. So this is Nobel Hospital in Nepal, and you can see our theater now. That is the OARM. This is in 2017. I had the intraoperative 3 Tesla MRI. Okay, I started off with just a suction and a bipolar, but we had the OARM, we had a 3 Tesla MRI, even when Europe didn't have a 3 Tesla MRI. In a godforsaken place like the Bihar border of Nepal, we had all this. We had the poinsettia robot. We had, for the endoscopic arm, we had the IDA. We had the IDA system, the Karl Stoss 1. We had the whole world coming there. So this was with Yasagil and Professor Yuha Parthi. This is a cystonostomy summit, and we had fellows from all over the world. Okay, he's from Egypt, from Mexico, from Italy. It is one time. This is just one time. This is from Peru. He is from Peru, and this is and this is Mount Valletta. And this is after that, when we went to Krishna, we had the intraoperative CT scan. And instead of the MRI, we thought we will have the intraoperative CT scan. But it was, this is the robot, the Esculap EOS, which we were, and this is the hypervision. You can see how we are improving over time. A lot of people tell me, oh, I don't stay at one place, but this is my part of the career where if I have to improve something, then I have to move. This is the lab there. We have a much more beautiful lab right now. This is the intraoperative CT. And then, this is all our work in different parts. And this is the IMRI, with Times Medical. This is a 0.35 Tesla single room IMRI, the first one in Asia, I believe. And it is a single room IMRI. Isawate was also got a 0.15 Tesla one, and that's the world's single room IMRIs, and they're one of the pioneers. But we have We have all this combined with the exoscope, and even this shark, this whale shark, is going to be in my theater. So you will see that this is how it is done. So this is the Sanmayoko exoscope. You can see the IMRI, that's the table, that's the navigation. We have the VR, machine learning, XR, extended reality, all with it together. So that if I say, hey, Meda, get me yesterday's scan, reconstruct, segmentate, and show me the perforators, it will show you. Okay. So it is technology, but it is important too. Okay.
Sorry, AP,
This is
can you sorry,
yes.
I just whatever you showed, I'm just seeing your intraoperative pic. I mean, like video. I'm not sure my internet's got issues or everyone see the same thing, or this is right now. I'm intraoperative thing is showing in my sites. I'm not sure. The other people also see the same.
Is it showing?
The slides are running far behind your talk. So we are now looking to the glomus ugularis tumor.
Yes, it's looking like that. I think you show a lot of beautiful things. That's why, if you can a little bit like reverse it back.
Oh, the glomus jugulare? That is what you're looking?
Yes,
that is far behind.
Yeah, yeah, because you show
I'll
a lot
stop
of
sharing.
Yeah.
I'll stop sharing and share again. Oh, that's I'm really sorry for this.
That's okay.
Yeah, so I share again.
But we listened carefully to your talk. It was very
yeah. Thank you so much. So I will this is the glomus jugulare. You can see that?
Yes.
You can see that. Yeah.
Okay, now I go to the next slide. This is a total internal decompression concept for vestibular schwannomas. Can you see that?
Yeah, that's we can see. Yeah.
So you can see the nerve. You can see this red thing is the vasculature. That is the capsule. And usually people dissect the capsule away from the vasculature, and that is what produces all problems. So what we do is we go in, we keep the capsule. Can you see that?
Yeah, we can see that. Yeah, from the top.
So what we do is we take we keep the capsule there, but this capsule, don't think that it is tumor. It is the perineurium of the vestibular nerve, and it is as thin as an arachnoid membrane. So you can see the seventh nerve through that. You can see the eighth nerve through that, but you never peel it off. This is something that I want to tell all of you. First, identify the posterior surface of the capsule, open the capsule, take out the entire tumor, and put in your endoscope, and you stimulate the seventh, eighth through the capsule. You'll be able to get a beautiful resection. It'll take some time for you. It is very likely that you may leave a little bit of tumor in this place, but nothing happens. You can open the IAM. You can remove all this tumor, and your patient will be as fresh as a lily next day. Instead of after having taken this capsule away from your seventh and eighth, you don't know whether you are lucky or not. If your seventh nerve is preserved, eighth nerve definitely will not be preserved. So here, this way, seventh and eighth will be preserved and no recurrences. And this is the multi-window total internal decompression in craniopharynx. Can you see that? Can you see?
Yeah, we can see that. Yeah.
Right. So this is the concept of multi-window total internal decompression. This is the drill that I can use in an endoscope. Can you see this drill, please?
Yes, we can see that. Yeah.
Yeah. So I will ask now. I'll confirm that whether you can seeing it. You're seeing it. See the endoscope. Can you see the drill is moving? Can you see the drill bending?
Yes, you can see it.
Yes.
And the beauty of this drill is it is It is a reciprocating drill. It is a reciprocating drill. So that if it touches your hand, nothing happens. It is rotating at 80,000 RPM, 60 degree to one side, 60 degree to the other side. It will take off all the bone, but if you touch the carotid, nothing happens. Because the carotid will 60 degree, it will move with it. Okay, it will not harm the carotid at all. If you touch the dura, you can keep the drill on the dura for 5 minutes before you notice any damage. That is the beauty of this drill. Okay, it is such a disruptive thing. You will all start seeing it very soon. And because it is only rotating, it is easy. It is very easy to make it bendable also. So it is completely disruptive from all. So you can see it is bending. So you don't need all your transmaxillary, transpterygoid approaches and all that. You want to go anywhere, you can drill it. And if you touch the dura, nothing happens. Okay. Of course, that doesn't mean that you keep on putting it on the dura. You don't test it, of course. But if you touch the dura, nothing happens. Now, this is the STMC revascularization for strokes, as I told. Can you see this? This is a STMC ST2M4 revascularization. You can see that it's about 12 sutures. Sometimes I put 14 sutures. And I want all of you to start this for your stroke patients, okay? You should start it. It's very, very important because your stroke patients will do fantastically well. I mean, imagine everybody is doing cardiac bypass. Why it is the same vessels. Why can't you do brain bypass? Especially there is no plasticity in the heart. While there is plasticity in the brain, all the more reason that you should do brain bypass for strokes. But everybody is into cardiac bypass because cardiac bypass can be done with just 4.5 magnification with just loops. But of course, you cannot do that with STM4. You cannot do STM4 with loops. You need good microscopes for that. And this is can you see this? Can you see this image? This is a 0.7 to a 0.25 millimeter bypass.
We can see it, yeah, beautifully. Yeah.
Yeah, so these are our, this is the exoscope. And this is when the last week I was in ACNS, I was leading along with Taki. I was leading the microvascular anastomosis workshop with Ashish and Taki and Keki. So this is the set. Can you see the set? This set is, available in India, and it costs only half the price of one scissor from the other companies. I mean, for example, the Japanese companies or the Western companies, one scissor will cost, double this entire set. And this is one of the, I can assure you this, the quality wise is one of the, because we took 2 years for it to be done, and it is ultra micro neurosurgery ready. I do all my anastomosis under the exoscope with this set. And so it becomes very easy for the young neurosurgeon to, acquire one and start it. So as I was telling you, Luis Borba just acquired one. And this is the mosaic approach. And this is with just a single eyebrow incision. And you can see how my colleague is wearing the exoscope and doing this. Can you see that video?
Yeah, we can see it. Yeah.
Yeah. Oh, I'm so sorry that I missed everything before. So now you can see that is the carotid, that is the optic nerve. This is just through the eyebrow incision. Okay. I have done a transcavernous dissection all the way. You can see the retractor on the lateral side. That's a cavernous sinus. That is the third nerve entering the cavernous sinus. That is a fourth V1, all that in the cavernous sinus. That's a posterior clinoid process partially removed. That's a basilar. All this with just an eyebrow incision. And you will see very soon now how is it in the case. We can use both exoscope and endoscope. And this is, you can see, can you see this image? Can you see the video?
Yeah, we can see it. Yeah, we can see it.
So you can see now, you can see the the vertebral basilar junction, basilar perforators, superior cerebral artery. This is the posterior cerebral artery. That is the third nerve coming up. So you can see the fifth nerve here, the seventh nerve there, everything in this approach. You can see the optic, carotid, third nerve, every single thing you can see with this. This is just with an eyebrow incision, okay? And I'm sure all of you, the whole skull base community will be going into approaches like this. But so this is Nobel Medical College. So that's our theater. You can see the O-arm there, the intraoperative 3 Tesla MRI there. This was 10 years back. So we established this in Nepal 10 years back. And these are various places. These are our fellows, Egypt, from Mexico, from Italy, from Peru. And this is how we used to chill out. And this is the intraoperative OTMR from Nepal. I moved to India, to Karad, and this was the theater, and this was the IOT. So if I can establish it in 3 different places, I'm sure each one of you can establish it in one place. I'm sure you just need to push it so hard that it is irresistible. You have to make sure in your place. So this is the robot. You can see the robot. This is the hypervision. Can all of you see the videos?
Yeah, we can see. We can see the Krishna Institute. Yeah.
Yes, the Krishna Institute. This was where we had the intraop CT, but then we realized that intraop CT and intraop MRI both are good, excellent, but intraop MRI. So in the present place, this is our work in South America, and this is where Medharanya is. Medharanya is the IMRI suite, and you can see the IMRI suite and the Yoko Sanma Yoko exoscope here. You can see that's a IMRI. That's a open MRI to which it is a single room. It's sitting in my OR, and my OT table can just swing in because it's an open MR, if you notice. And this is the exoscope, and I can have with the XR, I can have all the things into my exoscope registered. So carotid, even if I'm not, so let us say there is a bleed and I want to see the aneurysm, the hypervision will be switched on and I can see the aneurysm through the bleed. Okay, these are the benefits of these kind of things. And this is the unified theory. So this is for fear, how to control fear. We do a course on this, and I mean my partner on this project is Mr. Mon Nimrod Brockman. He was the mental fitness coach for many world class. I mean, in fact, the world #1 badminton player, and as well as he was also for the Rajasthan Royals in IPL. So we look at all the parameters, and like elite athletes, we train neurosurgeons how to operate without fear in flow. And this is something that I want. I don't know whether you will hear the voice, but this is something I want to tell you all the time. I want to tell all my students all the time, because why you don't do anything, because everybody tells you, oh, it's not that simple. It's not that simple. You cannot do it. But this is a movie clip I want you to see. That's a lie. Okay. The biggest lie he's ever been told is it's not that simple. So remember, when somebody tells you it's not that simple, you remember that this is what you want to do. When you hear impossible, think it's fun. Okay? And of course, don't listen to anybody who says that life is all about neurosurgery. You must worship neurosurgery and things like that. No, neurosurgery is your profession. Do it very well. Go climb the mountains of Afghanistan. Okay, do trekking and live life. Thank you very much. God bless. And if there are any questions, I'll be more than happy to take it.
Thank you, P. That was fantastic. That was magnificent talk. Because I've seen all of your talks. I think it was really inspiring. It might be inspiring more. So we do have audience from Malaysia, Afghanistan. I'm sure I just shared the links to your group as well from all around the world. Basically, I can see a lot of names. And we shared this once on YouTube as well as on our Facebook channel. So that was really, really inspiring because you see, you're one of the inspiration for me as well, because you've been in Nepal, then you moved to India. You're basically to being in our part of the world, because if you tell this story, someone's from America or Europe, I think for them is to digest, understand is like a little bit difficult. But I think you understand what the life looked like and how hardship is that. But as you said, if it's not possible or it's not simple, I think that's the biggest lie. I think everything is possible. So I just will go with that one. So I think I will open the floor for the questions. If anyone have a question, I think you just raise your hand, we'll pick you up. Then Prof. Ip is here to answer your thing. And then we'll have some level of conjoined kind of collaboration or something from Afghanistan or here. We'll talk about that one. Any question, any comment? Prof. Ip Pichiran showing you a lot of nice videos. All right, we will pick up the Sinuzu Chibu, I think. Go ahead. Sinzu. On your mic, please, Sinzu. Okay, unmute your mic, please. While Sinzu will come, AP, I'll just put it a little bit of in perspective. So, I mean, you're right, actually, since 2009, start talking on cystonostomy, and there's a lot of basically resistance to that. But I think now there's not much more resistance. I can see that, it's like reaching to acceptance. So what's your thought on that, and where you are now with that kind of concept?
Well, now, even United States, there are surgeons doing cystonostomy. So that was where the resistance was from maximally. The problem was when we started doing cystonostomy, two things changed. Number one, senior guys had to go into theater in the night, sit down with a microscope. That was not very easy on them. The second thing was most hospitals doing two surgeries without any guarantees were asked to, do a difficult surgery for the same price. And the last thing that changed was one of the biggest businesses in neurosurgery is cranioplasty plate. In a hospital like in a major center in one of the major cities, 15 decompressives happen in one day. Imagine $1,000 cranioplasties for all those all those decompressives. And the problem is most of these companies producing these, they are sponsoring many of these journals. So there is always a pressure, and I've always talked out open about this. People have always told me you have to be politically correct. I don't think I'll ever be politically correct. So these were things, and youngsters were misguided in trauma to be writing too many papers than achieving surgical skills. Now all this is changing. I was fighting for it all my life. All my major career, I was fighting about it. And today I see the youngsters, they are so much into surgical skills. When I do a workshop, I don't have to talk about it. People come in, okay, and people want to come and learn skills. And those days are gone now. So I'm so happy that, it has changed. So it was common sense, I thought, way back in 2007. And because, people didn't accept it, I was not happy, of course. But, Ahmad is also here. So he knows the entire story as well. So right now, there's a lot of acceptance. People from all parts of the world, all continents, they do cystonostomy. They have excellent results. All my fellows from Europe, they have gone back and started cystonostomy, and they're finding excellent results. So I don't talk about cystonostomy anymore now. There are so many people to talk about cystonostomy now.
That's what I observe actually. Yeah, that's what I observe. I think I'm almost like fearing cystonostomies. I think you have. So we're going to pick up Sinzu, the one like raise his hand. I'm not sure. Do you have a question? So if it's not the question, I'll ask Dr. Burhani. Do you have any questions, Burhani? I'll just start. Professor Burhani is basically one of our colleagues. He's Afghanistan, but he's practicing. He's a neurosurgeon. He's in Netherlands, in Holland.
Yeah, thank you, Dr. Javed. Wonderful talk. I enjoyed. Your slides were moving slowly, so I thought it is very careful operation. So, but afterwards it was okay. Just everything I had heard previously. Also, your talk. To me is when I came to the Netherlands. I was in AMC in Amsterdam. There was a neurosurgeon. He was performing at that time. That is about 20 years ago. And he put every time after clipping aneurysm, kind of drain in the cistern. That was his idea. Just to drain all the blood rest there, so to minimize the chance of vasospasm. And other operation of you see in the for schwannoma, just that is very brilliant, just to not to damage the capsule itself, because there are all the neurovascular structures. So I think you are a good example for all the neurosurgeons, young neurosurgeons who is embracing challenges. You put the restrictions, turn that to opportunity. So for us in Afghanistan, we confront the same challenges. And you can all the day just be busy with restrictions, but you give us and our young neurosurgeons inside our country just open mind and to go on to embrace the challenges, and you make your own way to improve the things. One question I had about the using of the exoscope with the microscope endoscope. I know this is very difficult to have all the things in one small space. Do you have some kind of hybrid chamber room, or just use the simple operating room?
I can show you a video of how I use the exoscope and the exoscope and the endoscope together. Maybe may I share, Javed, just for a minute, so I can show them how I use both together.
Sure. Mustafa John, can you allow him, Prof, to exchange, put him as a co-host? Can you share your screen now, PP?
Yeah. Kajapane, can I have the charger, please?
Yeah, the host. Oh, okay.
Can you see my screen?
Yes, we see, but many screens.
Many slides. There's a lot of slides. Yeah.
Yeah, I know. I am just looking at where I have that. Oh, maybe I'll show it from the. I'll show it probably from the internet, or maybe let me see if I have it. Yeah. I have it. Can you see the screen?
Yeah, we can see the screen, but with multiple slides. The slides open. Yeah.
You are not. Are you able to see the video?
No, I think you can get out of this one. So you close the sharing screen again, reshare that one. Yeah.
Yeah. Sure, I'll do that. Can you see the video?
Yeah, we can see it.
Yeah, this is a very small interhemispheric approach, which I am using to remove callosal epidermoid. Now, and the last part, you can see, can you see the endoscope, 3D endoscope? Can you see the endoscope going in?
No, we cannot see the endoscope. Yeah, now the endoscope is coming up. Yes, I can see it.
That's the endoscope there.
Yeah.
And this is the endoscope. This is a 30-degree 3D endoscope. So you can see the tumor being removed there. And the exoscope, I can see the endoscope going in. Because with the exoscope, I cannot see the other side of the fox. But with the endoscope, the circular window, you can see the other side of the fox and the tumor and the A3 vessels. So I'm removing it.
Excellent. Yeah.
Can you see that?
Yep. Very beautifully.
Very clear, no?
Yeah, very clear.
Yeah. So this is endoscope assisted exoscope surgery. So the previous professor who asked me, I wanted to show you. Now I wanted to show you how it is in my theater. So you can see very small craniotomy. It's a hardly 5 centimeter craniotomy. And you can see the exoscope on my right side. You can see the exoscope on my right side.
We only see
and
the
the splits.
We only see the exoscope.
Can you see the
exoscope picture only? I think
you can see the exoscope?
Now we
can you see the exoscope?
Yeah, now we can see the exoscope. Yeah.
And you will see the endoscope also now. You will see that the endoscope is on my left side. So you will see that from the once the picture comes to the other side, that is the endoscope holder. That is a Franca Amica endoscope holder. That is a robot. So exoscope is on my right side, endoscope is on my left side. This is the endoscope holding robot. This is the split screen for 3D. This is one screen is endoscope, one screen is exoscope, both 3D.
Excellent. Yeah, we can see it clearly.
Can you see that?
Yep.
In my new theater, I will also have the IMRI.
Excellent.
Thank you.
That was brilliant. Senzu Chibu. Yeah. Can you ask your question?
Can you get me? Can you get me now?
Yeah, go ahead.
Yes, we can hear you.
You can get me?
Yeah, can you?
Yes, we can.
Okay. So I'm a medical student from Zambia. Yes, who's planning to do neurosurgery. So I wanted to ask, especially on the part of the one that you had explained that it's not worshipping neurosurgery, it's not all about neurosurgery, there's also time to do other things. Is it that there's a time when you attain a certain level, or maybe you can just add more light on that one?
I did not understand your question very well. You asked me, what is your question?
But so my question is that with regards to neurosurgery, how is it? Is it that all the time you'll be just in the wards, or maybe sometimes there's a lot of time to also do other things? How is it?
So he's saying that, okay, Sinzu is from Zambia, actually is a medical student. And basically his question is basically neurosurgical is very busy schedule. He said that how you divide your time apart from neurosurgery, you do all the other things. He said that you just want to know about it.
Yeah, so after being 20 years in neurosurgery, now I'm the director of the program. So I have neurosurgeons with me. We do about 100 cases a month. And so I have neurosurgeons. I have 2 units with me. So I operate around 4 cases a week. That's it. So I get time for innovations. I get time for doing other things. But please don't think that from the day one you'll get time to do everything. You'll have to be 26 hours into neurosurgery in the first 10 years of your career after you finish. And after that, if you work like that, then you earn your freedom. So first work like that. If you don't work like that for your entire life, you'll be doing about 5 hours to 6 hours of neurosurgery. But if you do 26 hours of neurosurgery every day for next 10 years, then you will earn your freedom to do maybe about 1 or 2 hours of neurosurgery, and rest of the time you can innovate, and you can earn, and of course you can travel the world and do other things. But first 10 years is mandatory.
Excellent.
Okay.
So
Thanks a lot. I've understood.
You're welcome. I hope you got it. So I think AP, I just want a little bit of the reason is I bring you to this platform. I think Afghanistan is now growing up and they were developing very fast, like as you've seen in Nepal and what you saw. So we're developing really fast neurosurgicals. We want to uplift them as well. So there's a lot of things. So how can you help us out in terms of training, in terms of like fellowship? Now Afghan government in India have a good relationship, so we have to take advantage of this. If you want to like this for further, I think fellowships for your courses and everything, we either invite you or you invite us over there. So